Thank you for joining us. My name is Theron Steinke, and I am honored to introduce you to our team of clinical educators and local prosthetists and orthotists. It is our firm belief that patients living with limb loss receive the best outcome possible when we take the team approach to their care. The relationship between the prosthetist, therapist, physician, and other treating medical professionals starts and ends with open communication and education. We learn just as much from you as we hope that you learn from us, and it is our goal to make these presentations a conversation, not a lecture. We sincerely thank you for your support and devotion to this specialized patient population.
Hi, my name is Brooke Osteen, and I'm an occupational therapist. I work for an orthotics and prosthetics company in the Midwest, presenting education to both practicing therapist students as well as consulting with our practitioners for patients with both lower and upper extremity amputations. I have worked in a variety of facets in the industry, working for 2 years in acute care and hands, 6 years as the lead OT in the burn center, 1 year in medical sales, selling dynamic splints, and most recently, 8 years for SRT prosthetics and orthotics as the OT on the upper extremity team. My passion is helping as many people with amputations as possible through the training of therapists in all treatment settings. I want those therapists who may only see a few amputees a year to be just as comfortable as those therapists who see many amputees each year. I also want to encourage interdisciplinary care with our PTs and our PTAs so that we can achieve the best functional outcomes for our amputee patients. Hey there, in this presentation, we are going to talk about lower extremity ADL retraining. Basically what I'm saying is we're going to make you as occupational therapists just dangerous enough to learn the pieces and parts of a lower extremity prosthesis. As you all are aware, I'm sure, we're seeing some big changes in healthcare industry, from bundled care to insurance companies being pretty restrictive on how many pieces and parts they will actually give an amputee to support their prosthesis. And so it's super important that we teach these patients good habits because as we all know, it's super hard to teach an old dog new tricks. So what I want to give you today is just some tips and tricks and some information as an occupational therapist, how you can support these lower extremity patients so that once again, we can get them their best functional outcomes possible. I should also tell you that some of the things that I'm saying or some of the things that I may refer to may not be the exact way that it's done in your region. And so here's my encouragement to you is always pick up the phone and reach out to your local prosthetist or practitioner just to see exactly how they want things done as well. Okay, so first things first, right? We need to get some compression on this residual limb. Typically, that's done through a shrinker, okay? Shrinkers can come in a little bit of different forms. I'm going to show you a trans-tib or below knee shrinker today, all right? What you need to know about a shrinker is that it's a physician-driven item, okay? Meaning the practitioner or prosthetist cannot put this on a patient unless there's a script or an order written by a physician. So first things first, get a script, okay? Next thing is the donning process or getting the shrinker on a patient's limb, right? What we need to remember is that this is going to be a relatively acute amputation. So you as a therapist are going to go in so excited. Hey, your doctor cleared you for compression. We're going to get a shrinker on today. And the patient's going to be like, whoa, hold the phone. You're doing what? And bringing what near my residual limb? So best to maybe show them first what you're going to do and talk through the process, okay? But as far as the donning process, it's very similar, I would say, to get pants on a leg, right? So my recommendation is that you bunch it up, okay, much like you would, again, the leg of a pant, and you make the hole as wide open as possible. Now, this shrinker has been stretched out. This shrinker is bigger and wider probably than most. So guess what, guys? I'm making it look really easy, okay? What I can equate it to is putting a pair of TED hose on a patient for the first time. I don't know about you, but I think about TED hose and I start to sweat, okay? Shrinkers are going to be something similar. They don't need to be intimidating. Just do what you can. So one tip or trick, or what I like to do, is I like to actually open the shrinker as wide as possible. And rather than me pushing it on the patient's limb, I actually have the patient push into the hole of the shrinker. So I stay stable and have them push in with their limb. So as their limb pushes in, what you would do then is just pull the shrinker up their residual limb. Okay, something similar like that. Now, I will show you on this style of shrinker, there's a ring on the end, okay? It is super important that that ring goes all the way to the distal end of the residual limb and it doesn't have any gapping, okay? Reason for that is fluid is lazy. It's kind of like a sloth, right? It doesn't move or go anywhere until you make it do so. So if we leave a little bit of a gap, fluid is going to sit at the end of the residual limb, okay, making that distal end a little bit bulbous or wider, and it's going to be hard for the patient then to push into their prosthesis. So make sure that ring is nice and snug and tight, and then you're going to reflect the second layer on the patient's limb, okay? Reflect, it's just a fancy word that's used in the prosthetic industry to say we're going to put the second layer back on the residual limb too. So something like this, okay? Couple of key things to remember is these two blue lines. If you happen to have a shrinker of this style, my preference is that these two blue lines actually don't meet in the same location, okay? What that can actually do is cause choking of the residual limb. Easiest way for me to describe that to you is, ladies, when we go to sleep and we leave a hair tie on our wrist and we wake up in the morning and we've got that perfect indentation exactly of where our hair tie is, that's called choking, or that's an example of choking. So what that can do actually is increase the pain and swelling into the residual limb because you're stopping a little bit of the flow of fluid, okay? So two blue lines shouldn't meet, all right? Well, let's really get to the nitty gritty of the OT stuff with the shrinker, and that's wear and care, right? So I think as therapists or as OTs, we think, oh, it's got to be something similar to like a splint schedule, right? We're going to put it on for 2 hours and we're going to check the skin and then we're going to take it off. Well, I'm here to tell you that's not the case. Don't freak out, but it's 23/7. So once that shrinker goes on, okay, we need to leave it on. Research shows that when it does come off for any period of time, that fluid does actually start to reaccumulate in the patient's residual limb and can potentially delay the prosthetic process. Now, that being said, use your best clinical judgment, right? I'm giving you recommendations. I'm not giving you an ultimatum. So if you have a vascular patient that has a sensitive residual limb, or you maybe have somebody that we know has compromised skin integrity, then by all means, please use your best clinical judgment and remove the shrinker as needed to do some skin checks, okay? Now, care, right? Again, let's teach them good habits because an old dog doesn't learn new tricks very easily. What I really like to do is teach the patient to actually wear the shrinker into the shower or the bath when they're bathing. Now, some patients are going to say, are you kidding me? I have an amputation. I'm not getting into my shower. Okay, well then let's take care of it while you're doing your bird bath at the sink level in the bathroom, okay? So they would have it on until they do their bathing task. They're going to take it off at the same time that they're bathing their body. With the same soap that they're going to use on their body, they're going to use that same soapy water on their shrinker, okay? They're going to get it all nice and suds up, give it a squeeze around to get it nice and clean. They're going to rinse it again, rinse it one more time, and when they think they've rinsed it enough, maybe try one more time. And the reason I'm putting such a big emphasis on that is you have to think about what's going to happen when the shrinker goes on to the patient's residual limb. What we're doing is creating a dark, warm, moist environment, okay? So if they don't get that soapy residue completely out of their shrinker, then sometimes what you see is a reaction or a skin irritation. Because that residual limb is warm and the pores are open, if that soap residue stays on the shrinker, then it gets into those pores and can potentially irritate the patient's skin. So it's super important that they do rinse these thoroughly, okay? They are going to get two, one to wash, one to wear, okay? So once they've completed the care process of it, or the rinsing and the washing, what they're going to do is they're going to lay them flat to dry, okay? So 23/7, hand wash, lay flat to dry, all right? Couple of other things to think about when it comes to a shrinker, and especially with the transtibial patient or the below knee patient, is think about that backside of the knee, right? If they're highly active and they're moving around a lot, what you're going to want to ask them to do is to consistently look behind their knee to make sure that they don't have any wrinkles, okay? Because if that shrinker starts to wrinkle up, they may get some additional pressure behind their knee, which could result into some skin integrity issues or maybe even some slight blistering. So just make sure they keep an eye on it, and you do too. Okay. The other type of shrinker is going to look something like this, okay? So it looks more like a compression stocking. So it's just a single layer, slides onto the residual limb, and you kind of leave it. What I do like about this shrinker is it has some silicone banding at the top, okay? So it has a little bit of tack. So you're not going to see this one slide down or bunch or wrinkle maybe as much as you're going to see it in this shrinker, all right? A couple of other things to remember about a shrinker is that it should not interrupt the patient's sleep cycle. So if they find at night, because their phantom pain is more prevalent at night, that shrinker is super uncomfortable, if they're wearing the white shrinker, what they can do is just take it down to a single layer rather than completely taking it off. If they're in a brown shrinker and having some difficulty, then they need to reach out to their prosthetist and see if maybe they can size up one size, okay? One of my other favorite tips and tricks is if they are in this white shrinker and for whatever reason they're to lose that plastic ring, then we ask that you twist it and reflect it, don't knot it. A knot's going to add additional pressure and could potentially add a pressure sore at the end of the residual limb, okay? So that's the skinny on shrinkers, right? The next thing that we're going to move to are liners, okay? So this is the first thing that's actually going to go onto the patient's residual limb before they put their prosthesis on, right? So as you guys can tell, all of my liners look a little bit different, okay? All of the ends look a little bit different. This one's got some silicone rings on it, right? We're not going to get too far in the weeds on liners today. So I do want to tell you that they all look different because it has to do with the suspension of the prosthesis or how that prosthesis is held onto the patient's residual limb, okay? So if you have specific questions about that, I do recommend that you pick up the phone and you call the prosthetist and make sure that you're asking those questions. But for today, we're going to leave that aside, okay? So more or less, we're going to talk about, guess what? The wear and care and donning and doffing, things that are practical to our profession, okay? So let's talk about donning first, all right? So I do want to explain one quick thing about a liner before we talk about putting it on. And that's whether the liner is a uniformed liner or a non-uniformed liner, okay? Uniform liner meaning that gel interface or that thickness of the gel is the same front to back, okay? That comes in 3 millimeters or 6 millimeters. So uniform means it's the same all the way around. So the front is the same as the back and vice versa. And so the orientation of the liner when they don it doesn't really matter, all right? If it's a non-uniform liner, that means the front side of the liner is thicker than the back side, meaning there's probably 6 millimeters of gel mineral material in the front and 3 millimeters of gel mineral material in the back. If that's the case, then it does matter how you don it. And we want that thicker or that 6 mil to be in the front and the 3 or the thinner to be in the back, all right? Specifically, the company that I work for, SRT Prosthetics, I think was ingenious, right? So if we have a non-uniform liner, guess what we did? We put our logo on the front of the liner, and you can use that as a cognitive marker for your patients. So you would say, hey, Mr. Jones, when you put your liner on, I want you to make sure that the logo is always in front, all right? If your local prosthetic company didn't happen to do that, no worries, friends. Here's another tip or trick, is that you can actually take a Sharpie and mark on the liners, right? So maybe you can put some small indicator of the front or the back, again, as that cognitive or visual feedback reminder, so the patient can be more successful with correctly donning these liners if it's a non-uniformed liner, okay? A little bit more on the uniformed and non-uniformed. I know, I feel like I've got you at the grips of, okay, how do we get this thing on? I'll get there, I promise. So the other thing about a non-uniform liner, right? So uniform liner, so that everything is the same front to back, is that does have to be rotated, okay? So Medicare or CMS only allows their patients 4 liners per year. They get 2 at delivery, which should last them 6 months, okay? And then they get 2 later on. So it is important that they take care of these correctly, and part of that is, if it's a uniform liner, that they rotate them, all right? Textbook says it's supposed to be a quarter of a turn, so it would look something like this: seam in front, back, seam in front, okay? Here's another really good skinny, friends, is you are not going to find an amputee anywhere that's going to put that seam on the front side of their leg, right? I questioned this for the longest time. I'm like, how in the heck can they fill 6 millimeters with 6 millimeters of gel mineral material? How can they feel that seam? And they can, or at least they say they can. I'm not sure. I still have both of my legs. Point being, not a hill we probably want to die on, okay? So I'm here to tell you, even though textbook says it is a quarter of a turn, if it's a uniformed liner, okay, it is okay just to rotate front to back, okay? Now, from a therapy perspective, what if we do have a patient that is maybe cognitively compromised, right? And they need a little bit of cueing. Again, kind of like I alluded to on the non-uniform, you can mark these A, B, 1, 2, whatever you want. And maybe that's just enough of a reminder to them on how they need to rotate the liner, right? Or maybe we need to downgrade that a little bit, and we need to give them a little bit more information than just that marking on the liner. One of my other favorite things to do is actually print a calendar of the month that we're in. And then I mark on the calendar each day which side of the liner should go on the front side of their residual limb, right? So imagine asking a patient, hey, Mr. Jones, we're gonna put your liner on today, and you use that calendar. When you write your assessment, and maybe you have to write the best assessment of your entire life because it's a progress note, and we're trying to up Mr. Jones for more days in that skilled nursing facility or that inpatient rehab unit. Imagine your assessment when you make Mr. Jones go find the calendar, determine the day, determine which side of the liner goes in the front, finds his liner, and then puts it on correctly. There's going to be so much guts in your note on whether they can't or can't do that. And then imagine maybe mentioning the safety of that, because maybe we know that Mr. Jones lives independently, but he can't complete that sequence of steps. So how does that affect his safety in just charging to independent living? So just kind of some things to think about and stew on, okay? All because we donned a liner, all right? So now I kind of held you on for too long. So let's talk about getting these guys on, okay? So the first thing you're gonna do is you're actually gonna invert the liner, okay? Meaning you're gonna turn it gel side out, okay? So couple of tricks here, right? Somebody with maybe decreased dexterity, hand coordination, this can be a little bit difficult depending on how tight or how new that liner is. So sometimes I teach them just to use their thumbs, okay, and get that gel liner out. If you feel like maybe they've got some CMC arthritis or they just don't have the strength to do that, then that's okay, okay? Another tip or trick that I like is to actually get it so the gel liner starts to come out. And then actually, because that has some tack, what they can do is actually put it on their leg and they can pull. And you can see that too will very quickly invert the liner, okay? So we've got a couple of ideas of ways to get that liner inside out. So once it's inside out, here's what's probably gonna happen, okay, is the patient's gonna put a little divot in their liner, right? Because they know that the end of their residual limb is rounded. And they're going to say, oh, well, my prosthetist told me that that's the best way to put on a liner. Well, guess what, friends? They be lying, okay? I promise you, nobody told them that, right? So it is super important that that liner is reflected or turned all the way inside out, okay? So all the way inside out, total contact with the residual limb. And then they are going to roll, don't pull, okay? So a couple of reasons for that is that that gel mineral is attached to that fabric liner, okay? And so if they start to pull, A, they're gonna stretch out their liner, and B, they're gonna separate that gel mineral material from the liner, all right? Neither of those are medical reasons to replace the liners. So again, it's about teaching a patient really good habits right off the bat, okay? So what can we be doing, right? So maybe Mr. Jones is at day 85, right? He still doesn't have his prosthesis. We only have 100 days. So how do we give him some client-centered therapy, right, to get him ready for his prosthesis so that we can give somewhat of a simulated, sorry about that, situation so that we can document that he could potentially be independent with donning his prosthesis. Find yourself a piece of PVC pipe. Y'all, I'm a little bit weird, if you will. Best place for a Friday night date, hardware department at Lowe's, okay? Make buddies with them, right? So I always walk in and I'm like, hey, they see me coming, and he's like, okay, what do you need tonight? So sometimes I'll ask, hey, do you have a piece of PVC lying around that you might be able to loan to me? When you make friends with people, it's pretty interesting what they can find or how they can help you, right? So one of my favorite tricks is just getting a piece of PVC pipe and wrapping a piece of TheraBand around it, okay? So this is a doubled up yellow. So you can do a single layer, you can do a double layer, you can grade it with colors, you can do whatever you want. But it's a really good way to teach the roll, don't pull strategy, okay? So whether they hold it between their legs on a tabletop, whatever it means, okay? You can get them to use their palms, and then they're gonna roll that piece of TheraBand up and down the PVC pipe while you are saying to them, or they are saying to themselves, roll, don't pull, okay? That will help increase the life or the longevity of the liner, okay? So let's talk about wear and care. We've got it on. Now we probably need to talk about how we're gonna take care of it and how often we're gonna wear it, okay? Remember what I said about shrinkers, how I said, I'd like them to wear it into the shower or take care of it while they're doing their bird bath? Guess what? This is gonna be on repeat for liners. So I have found, and I feel like the more we can teach them repetitive skills that are the same, the more they're going to be successful and do exactly what it is we're asking them to do. So guess what I'm going to tell you? They need to take care of this in the shower, or they need to take care of this when they're doing their bird bath, okay? And guess what? The same soap that they use on their body, they need to use on the liner, all right? And they need to make sure they're washing the gel side and the fabric side, okay? And guess what I'm gonna say about rinsing? If you had to guess, what did you think I would say? Rinse it, rinse it, rinse it again. And when you think you've rinsed it well enough, guess what? Rinse it one more time. Why? Because it's the same concept, right? We want all of that soap residue off the inside of the liner because, again, we're creating a dark, warm, moist environment where potentially those pores are going to be open. And if we leave soap residue, that is an easy way to create some skin integrity issues. Now, I will tell you, maybe once or twice in the 13 years that I've been doing this, that I've seen somebody actually be allergic to the silicone that's in a liner. Usually if they have a skin integrity issue, it's because they're poorly managing the care of their liners. So not something that's horrible to review all of the time, or maybe even watch them do it successfully once or twice so you can give them a few tips and tricks, okay? So now, as far as wear schedule, so it is a little bit different than the shrinker, okay, in that they are going to wear that shrinker 23/7, okay. The liner is a little bit different in that they're just going to wear the liner during the daytime hours, all right, or when they have their prosthesis on. So this is not something that we want them to be wearing at night, okay. So early on, probably what you'll see is they will wear their, I'll get that out at one point, they will wear their liner during the day, and then they will revert back to their shrinker at night, just acutely, so we can help manage the volume or the swelling of that residual limb, so that when morning time comes and they need to get their prosthesis on, they're able to do that, okay? And in some instances, what we'll do, and again, check with your local team or your local prosthetist if they're able to do this, is that we will dispense or give the patient their liner maybe 48 hours and sometimes a week before they get their prosthesis, especially if you know somebody that might be a little bit cognitively challenged, so that we can sequence the steps of donning their leg and it's not all at one time, okay? So just kind of to keep that in the back of your brain, see if that might be beneficial to your patient. Pick up that phone and give that prosthetist a call, okay? Another important thing to remember about the liners is the storage of liners, okay? So when patients take it off, they almost just roll it off, and it seems like that gel interface is on the outside, right? The big key to remind them is that it should be stored gel side in and fabric side out, okay? And here's why. So when the gel liner is actually on the outside, it actually puts that gel liner on stretch, okay? So if it's on stretch for too long, what's gonna happen is it's actually gonna decrease the integrity of that gel liner, and there is some potential that it will dry rot or crack, okay? Again, because it's poor management of care of the liner, that's not a reason for medical necessity for insurance to replace these, and they're kind of costly, right? I don't even think I want to tell you how much they are out of pocket, so let's just make sure we're giving them good habits to take care of them. The other reason that it's important to store these gel side in is think about that patient that's maybe in, again, an inpatient rehab unit or a skilled nursing facility, okay? They participated in their 3 hours of therapy during the day, and you know what? They're just wiped out, and they've decided, oh, I'm gonna take a little bit of a siesta or a nap before dinner or before lunch, right? Take their leg off, lay in bed, put their liner on their prosthesis, and they're out like a light, right? Well, in comes environmental services to clean their room. They give the obligatory rat-a-tat-tat on the door and say, hey, environmental services, I'm here to clean. Well, maybe the patient is so deep asleep that they don't wake up. Environmental services comes in and cleans. What do they have? They have a lot of aerosol chemicals, right? So it's not like they would purposely shoot the liner with the aerosol cleaner, but those particles are going to be in the air, right? So if the gel mineral side is out, there is a chance that some of those chemicals then will get on the liner and then potentially go on the patient's skin, okay? So just something to be aware of and watch out for as your patient's storing your liner, okay? Okay, so that's what I got for liners, all right? Now we're going to talk about socks. And not the kind of socks that go on your feet, although I'm going to kind of correlate that. So when an amputee walks, right, they walk their leg. That leg is weight bearing, meaning every single time they take that step, some of the volume of that residual limb is actually going out of their leg, right? So they may find by the afternoon hours, and especially your more active patients or your patients that are walking a lot, that their socket maybe feels a little bit loose or slightly sloppy, okay? They got some space in there that we need to take up. And guess what does that? Socks, they do the trick, okay? So socks are what is going to take up space in the socket as it gets loose, okay? They come in different plies, P-L-Y, plies, or thicknesses, okay? So the first is a single ply, right? So it's a super thin sock. Because I call this the Sunday sock, right? So it's thin like that. It reminds me of the frilly socks that my mom put on with the little, doilies on the edge of your sock that you wore with your patent shoes to church on Sunday. So I always call this the Sunday sock, but it's also a single ply sock, okay? There's also a sock, and again, these are the plies that our local prosthetic company uses. Our prosthetic company uses. Your local company may use something slightly different, so make sure you clarify with them what their typical plies or thicknesses of their socks are, okay? The yellow ring stands for a 3-ply, and the green ring stands for a 5-ply, okay? So that tells the prosthetist how thick the sock is, okay? One of the most difficult things that an amputee learns is sock management, all right? I'm not here to teach that because I myself sometimes think that I truly still don't understand it either, right? So one super good question to ask the prosthetist is what is your standard of adding a sock or taking away sock, right? Make sure that you understand that when they're looking at the socket or when they're hearing the patient talk about the fit of the device, that you understand what their parameters, again, for adding a sock or taking away a sock are. And if there should be any question, guess what I'm going to tell you? Pick up the phone, give them a call, okay? But I do want to teach you some tips and tricks, right? So much like the liner, they are going to say, well, my prosthetist told me, and this is about the order of how the socks go on, right? Goes, it should go 5-3-1 or 1-3-5, right? Whatever the reason, they're going to make up some sequence in their head about how the socks go on their residual limb, right? Guess what, guys? Not a hill to die on, okay? So whatever the sequence is that they've come up with, that's fine. Let them do it. Just make sure they're doing it right and that it meets those parameters that the prosthetist suggested for sock management, okay? Another thing I want to show you, or another tip or trick, is sometimes a patient doesn't need a full sock, okay? So maybe just the bottom half of their residual limb needs a sock. And so then what happens is the prosthetist cuts the top off, right? So they remove the top of the sock and they look at Mr. Jones and say, hey, Mr. Jones, remember I cut your 5-ply socks at the halfway point, but I cut your 3-ply socks at the 3/4 way point, right? Well, at the day of delivery or sometimes at the time of adjustment when they're having troubles and we're talking about socks, it's a lot for the patient, right? And so I think the practitioners or prosthetists are like, yeah, I totally educated Mr. Jones about this. I even went over it twice and maybe even wrote it down. Well, if it's around the delivery or maybe around an adjustment or they have an open sore or something like that, Mr. Jones might not be comprehending all of that information. So what I like to do to remind them what the ply is take a Sharpie marker and write the number as big as I possibly can on the sock. So a 3 on the 3, a 5 on the 5, right? That way there's absolutely no guessing how thick that sock is, right? And does it really matter that there's writing on the sock? Well, no, because nobody's going to see it because the socket goes over that, right? So you have the patient's residual limb, the liner, the sock, and then the socket. So then the prosthesis actually goes on. So it will cover up that writing. So if that patient gets apprehensive about you writing on the sock, reassure them nobody's going to see it but the inside of their socket. Okay, so they need to wear these when the practitioner says that they need to wear them or when their socket indicates that they need some volume taken up or some space taken up. Okay, so how do we care for these? Here's the thing about socks, and don't tell anybody I told you this, okay? They get a boatload of them, all right? So if a patient says, I don't have socks, they're crazy. They'd be lying again, right? So they're going to get 6 single-ply socks. They're going to get 3 5-ply and 3 3-ply every single time they get a socket, okay? So they have socks coming out of their ears. They have plenty of socks. So I always tell the patient, for ease of management, that if they want to throw them in the washer on the delicate cycle and put them in the dryer again on the delicate cycle or low temp, that's fine, okay? They're gonna get enough of them. And in fact, a lot of times they get so many of them that they use them, their wives will use them as a dusting rag, or they'll use them in their garage as a garage rag, okay? So that's it on socks, okay? So there is potential that there might be a couple of different other items associated with the socket that assists in suspension. And because that's so different for every single patient, that's not something I'm going to directly address today because it can get super confusing, all right? But what I do want to talk about are a couple of other ADL items that are specific to the lower extremity amputee. And I specifically want to talk about AK sockets and toileting. Why? Because as OTs, guess who deals with code browns? We do, right? So there are a couple of tips and tricks here, okay? So again, one thing that we do locally or with our specific company is we will actually cut a U shape out of the backside of the socket, okay? And we'll expose the inner plastic, inner socket of the device, okay, on an AK patient. And here's why, right? So think about the AK patient and sitting down on the toilet for the first time, right? Can be a highly intimidating experience. They have to manage their prosthesis, meaning they have to know how does the knee lock and unlock. They have to manage their clothing. They have to do a stand to sit and pretty much in a controlled fashion so that they don't A, plop down on a really hard surface, or B, this is why we cut the back of it out, that when this hard round surface meets a hard flat toilet seat, they don't do the toilet seat shuffle, right? So the toilet seat shuffle is going to result in the socket hitting the toilet and the patient either sliding between the toilet and the tub or the toilet and the vanity or merely just on the floor. And who wants to fill out an incident report? Not this girl, right? So again, something that we can be talking to the patient about some tips and tricks and strategies for that stand to sit toilet transfer before they even get their leg or maybe even before they go home, okay? So as a therapist, I'm always harping on my practitioners to cut the U out of the back of the socket because it does expose that flexible inner socket, right? So it's got some give to it, but it also has got some tack to it, right? So when this hits the toilet seat, not only does it flatten, but it sticks, okay? So they're not going to go flying off the toilet seat, all right? The other thing that I like to do is go to the dollar store. So I might like the dollar store about as much or more than I like the hardware department at Lowe's or Menards, right? It's a toss-up on any given day. But what I love at the dollar store, Family Dollar, Dollar Tree, right, whatever one you have, Dollar General, whatever one you have, is I like their shelf lining. So not the flowery stuff that grandma has in all of her silverware drawers, right? But it's a little bit puffy and foamy. And what you can teach the patient to do is actually circumferentially wrap the side of the toilet seat that their device is on so that when they go and sit, and if they don't have this U out, or even if they do, that then when their socket comes in contact with the toilet seat, it will stop them and give them a little bit of tack, plus it will prevent their socket from beating up or eating up the toilet seat, okay? Try it. I think you might like it, okay? One other thing I want to talk about with toileting is believe it or not, the patient's sitting posture on the toilet, right? So again, most AK sockets, but again, talk to your local practitioner and see how they fabricate or design their AK sockets. But most AK sockets have what we call ischial containment, meaning their ischium is inside the socket, okay? So I want you to think about for just 1 second, how close is your ischium to your evacuation port, okay? Probably pretty close, right? So what happens when the patient has an emergency situation and they go haul into the bathroom, they sit down, they manage their clothes, they sit down and they go to the bathroom, but they're sitting with a wide base of support. Well, actually what that does is actually brings the socket closer to the evacuation port. And so we've had more than one instance, or more times than I care to mention, an issue where a patient has actually brought a socket into the office because they've had that emergency situation, not thinking about their sitting posture, and actually gotten fecal matter into their socket and are unable to get it out, and it stinks, Okay, so again, something to think about and something that probably nobody else is discussing with your patient. So as OTs, we just need to make sure we prepare them for some potential situations so they're not having to problem solve in the height of an anxiety crazy situation. Okay, so again, just something maybe to talk to your patient about. One other tip and trick I'd like to talk about, and maybe you already know, so maybe I'm not teaching you anything new, is the plastic bag trick, right? So a lot of times an amputee isn't going to take their foot off their foot shell because honestly, it's incredibly difficult to do. It's another thing that when I think about it, I start sweating and I'm like, oh, please don't ask me to do this. And so a lot of times their shoe is already on their foot shell, and then maybe they need to feed their prosthesis through the top of their pant leg because the bottom of their pant leg isn't wide enough to go over the top of their socket, okay? So inevitably, I kind of think back to that time when I was on an inpatient rehab unit as a student, and I'd walk into a patient's room and they'd have a total hip or a total knee, right? And we'd educate them on a long-handled shoehorn or a reacher, right? And they'd have their shoes on and they'd be sitting on the edge of the bed in their skibs with their shoes on, like, hey, yo, dude, you forgot about your pants. So it can be somewhat similar with a prosthesis, right? They need to dress their residual limb with their prosthesis and then potentially put their pants on. So one thing you can do is actually put a plastic bag over the shoe and then slide the shoe through the pant leg, okay? I know you're thinking, does this really work? I've seen a size 15 shoe go through a pair of skinny jeans and sweatpants with no problem using the plastic bag, okay? So it's also a really good way to get the prosthesis off, okay? So here is another little tip or trick about the plastic bag is it's also great for them to maybe have in their back pocket. And we'll talk about an ADL bag in just one second. But as they're going out and about and reintegrating into their community, imagine maybe they have an emergency situation out and they're toileting and they're like, oh my gosh, I need to get these pants off. How am I going to do it? And they forget their plastic bag, okay? Here's another fun little tip or trick. Between those double doors of your local grocer is now usually a plastic bag recycling bin. All right, cardboard box, stick your plastic bags in. I read the fine print, right? Not a federal offense if you take one out rather than putting one in. So you may try that. I want to talk about an ADL bag. So we've talked about a lot of things. We've talked about a shrinker, we've talked about a liner, we've talked about a plastic bag, we've talked about socks. We've talked about a lot of things that the patient may need with them on a daily basis to reintegrate into their community. Because let's face it, right? No matter how much Miracle-Gro or Chia Pet seeds they put on their leg, it's not coming back. So they need to have the pieces and parts with them at all times to make sure that they can not only take care of their residual limb, but take care of their prosthesis. And so what I would suggest is that you create an ADL bag, right? So just some bag, if you will, that's designated for all of their pieces and parts. So it's got a spare one of everything in it. And this is always good to create, maybe, again, in inpatient rehab if they have all of those pieces and parts, or in an extended care nursing facility as you're preparing for them to go home, right? So just think about this situation. Think about being in an extended care nursing facility, and as an OT, you get the patient to the edge of the bed, right? You have them don their leg, they're dressed, they're up, sitting at the edge of the bed, waiting and ready to go. So when that PT walks in the room, they're like, oh my gosh, you've got all of this on, you're ready to rock and roll, and they can focus on physical mobility and movement. And they're like, hey, Mr. Jones, because you're up and ready to rock and roll, we're gonna go to the gym today and walk in the parallel bars. Well, imagine Mr. Jones taking about 3 steps and being like, ugh, I think I need a sock, right? The PT is going to stop dead in their tracks and be like, okay, I'll go back to your room and get a sock. Well, imagine the therapy gym is in wing Z and the patient's room is in wing A, and they got to truck it there and back to get a sock so that Mr. Jones can comfortably walk. Well, what happens if Mr. Jones has got that bag and he looks at the PT and says, hey, I got a sock, it's in my bag. My OT got me ready for you to walk me. Imagine how powerful that is, right? Because then you can look at the PT and be like, hey, you owe me, right? I get paid in chocolate. That's usually what I'll say to them, okay? And then think about that situation as they reintegrate into that community. And so I bring back that situation of them being out and about, maybe at the grocery or shopping, right? And they have an emergency situation in the bathroom and they need to manage that. Well, if they have their ADL bag with them, they have everything they need to not only maybe replace everything that's on their leg, but redress themselves and get out of the bathroom without an embarrassing situation, okay? So I hope you learned something. I hope maybe I gave you 1 or 2 tips or tricks or nuggets, right, that you can take away to help your patients. But more importantly, I hope I gave you a little bit of confidence that you're like, as an OT, I can do this. And I do have a role within these patients to ensure that we've got the best patient functional outcomes. Thank you so much. I hope you have a great day, and I'm going to turn it back over to your local company for any questions or concerns.